in smaller diameter needles, and the transdural way often is not feasible for the 19G needle. It's very hard to advance. So in these cases, the smaller diameter needles might be the better ones. Another question is, should I use suction or no suction when I go for biopsy from pancreatic lesions? And there's a difference of suction techniques. Dry suction is just suck with a syringe at the end of the needle. Wet suction means you fill the needle with water and then suck on the water to increase the suction. The slow pull means no air, no water. You just pull back the stylet of the needle slowly to create a little bit of suction and maybe less blood. And of course, you can go for no suction at all. And again, this is a quite crowded slide here. I've put together a number of studies that compare different types of suction. No suction versus dry suction, or dry suction versus another kind of dry suction with more volume, or slow pull versus dry suction. There's a lot of different combinations you can think of. And what you can see here is that there's no uniform result here. That means in some cases, suction is better than no suction at all. I think we can see that. And in other cases, it tells us that slow pull is better than just dry suction because there's less blood contamination here. And another group showed that wet suction using water inside the needle increases the cellularity and the adequacy of the sample. Again, this number of studies shows me here that there are still some open questions. I personally are using the dry suction and the slow pull method for most of my lesions. More important than the technique of suction, I think, is the biopsy technique. And one thing you have to think of is that when you target a lesion, let's say in the pancreatic head like here, you should advance your needle multiple times and you should change the angle of needle advancement. You can see on the right side quite nicely how the same needle went through these pancreatic lesions at least 4 times in different angles, and this increases the amount of tissue you got quite greatly. And by doing this, the authors in this rather old study here could show that the diagnostic accuracy goes up to 96%, which is a really, really high number. I personally cannot achieve in my department. We get up to 80%, which is still quite good in comparison to other centers I know of. And then, and these are the last few slides, there's always the question of sample processing. What do we do with the sample? Do we put it on a glass slide like this, smear it down and send it to pathology right away? Or do we put it in liquid like we do in our department here, and then we send the liquid to the pathology? When you smear, you have to first discuss with your pathologist fixation or no fixation in the endoscopy room. This is quite easy. When you do it in liquid, the question is what kind of liquid, sodium chloride, formalin, or cell culture medium. And then again is the question what happens afterward with this biopsy in liquid. There's a lot of different ways to work on that. And the most important thing is that you talk to your pathologist first when you start doing this, and talk every a few months again. Is everyone still happy? Are there new developments? Can we change something to our biopsy technique and to our sample processing to increase the accuracy of our biopsy process? But this is something you should always discuss in the team. The last thing I want to show you is how should we work together, the pathologist and the endoscopist. In some centers, and it's only half of the centers in Europe, there's a pathologist in the room with the endoscopy team. I'm not sure how it is in St. Petersburg. I'm happy to hear that later. In my place, the pathologist is sitting in a completely different building, so there's no rapid on-site evaluation. He cannot tell me after a few needle passes, yes, this is enough, or no, you have to go on. So I always have to wait for the path report later. We know that using ROSE, rapid on-site cytology, the results can get better. It is desirable to have this, and if the pathologist will not come to you, you should take at least 3 needle passages to a given pancreatic tumor. Another way of increasing the diagnostic yield is that the endoscopist is looking at the cylinder he's taking like this. You see a cylinder here, part of it is blood, part of it is liquid, and part of it is whitish tissue, which is most probably the tumor. And when you then divide this into 3 fractions, 1 the tumor or the whitish tissue, 1 the blood, the red tissue, and 1 the cytology, then you make it easier for the pathologist. But to be sure, this looks quite easy. If you do it in real life, you will find that the distinguishing between the red and the white parts is not so easy, and cutting this cylinder in the endoscopy room is also not easy. It only works if you got a 19G needle and a longer cylinder. So we try to do that, but in most times it doesn't really work. So to summarize my talk, EUS needle biopsy in pancreatic lesions surely is the way to go. The sensitivity can go up to 90% plus, which is a really, really good result. And you should always monitor how your own sensitivity in your center is. If it is below 80%, there's still something you can do to get better. Above 90% is rock star cool. There are performance differences between fine needle aspiration and biopsy, but it's not clear which is better, really. And this is because the optimal needle design for the F&B needle is still not defined properly. Suction seems to be a good thing. I use suction in most of my biopsies, either dry suction or slow pull suction. The way of sample processing is very specific, and you should always talk to your pathologist about this, how to do it as a team. And on-site microscopy is a desirable thing, but only rarely practiced. I don't even think that 50% of European centers can afford to have the pathologist in the room. But if it is possible, it's a really good thing. And please let me finish with some wise words from one of my favorite books here, Samuel Shem, already 30 years old. There's no body cavity that cannot be reached with a long needle and a good strong arm. And EUS needles are the longest needles I know of. Thank you.
Thank you very much, Alex, for your presentation. It was really interesting experience and interesting data that you have presented. You have just a couple of minutes for your Q&A period. And my first question is about seeding. So the proliferation of the cells from the fine needle biopsy is always there, whether we use CT or US or EUS. What do you think about this factor? Is it a really critical one when we do the endoscopic test?
That's a very good
investigation.
Evgeny, and I thank you for that. There is seeding. This is absolutely right, and seeding is more of a problem when you cross other organs that will not be operated on. For example, if we do take a biopsy from the lesion in the pancreatic head via EUS, we take it from the second part of the duodenum, which usually will be removed when there's a cancer operation later on. When you do it from the outside, percutaneously, you have to go through the skin, through the muscle, sometimes through the stomach, and then these are all organs that will not be removed in an operation later on. So the seeding problem is higher in percutaneous biopsies. EUS is better in this regard, but still, when we do take a biopsy from the stomach, let's say, in a solid lesion from the pancreatic tail, there is the risk of seeding because the stomach will usually not be removed later on.
Thank you very much, Alex. We are moving on to our morphologist presentation, and some of the things which you have covered in your last slides will be discussed in their presentations. Maybe it is beneficial for you to listen to get more a better idea of how it is now organized in Russia. So the material on morphology which you obtained, can you please tell us about it? Very many factors affect the result, as we stated in our morphological report. Hence, the presentation will be made by our lead expert in cytopathology department of our center, and dealing with the pancreatic lesions mostly. It's Tatiana Shestopalova, and I'm inviting her to be a presenter and giving the floor and the chair over to her. That was a really generous move on your behalf. Good afternoon, dear colleagues. For me and for us all, it's a real pleasure and honor to be part of this meeting and make a presentation. I'd like to share our experience on the complex morphological diagnostics material obtained during the EUS tab, and diagnostic challenges and the reason for inaccurate conclusions. And so this is the classification, the WHO cytological classification manual and cytopathology of pancreas, and this major three sources of our knowledge and inspiration. In our practice, we use the most recent edition of the digestive system tumors with its classification of the pancreatic tumors. It's the 5th edition. It was revised and enlarged and contains 3 major sections. One of them dealing with malignant epithelial tumors of pancreas. And in diagnostic process, we see no challenges with this section, and so this is a man of 50 years. So this is a lesion in the head of the pancreas. So individual cell smears, we can see individual cells with the cell nuclear atypology, and we can see here the histology result and others as a malignant tumor. The second most challenging section, which has both benign and pre-malignant tumors, cystic just glandular intraepithelial neoplasia and granular intraepithelial neoplasias and others. This is a major challenge for a morphological diagnosis. First and foremost, in the cytological material, we need to differentiate between these processes. We use cytological the classification of Papa Nicolau in pancreatic bilial group. It has 6 major groups. 1, 2, 5, and 6 are not challenging. They are quite easy to interpret and provide unequivocal results. Whether this 3, 4 groups, atypia, neoplasia, which is benign, and others, all the cystic neoplasias, which have different characteristics. Hence, our major task here is to just establish the tumor risk factor, mucinous, cystic, or others. are not crucial here, because the tactics will be determined by the risk category. It's going to be either a surgery or an observational management of this patient. With this here, when we deal with cancer, when we identify neoplasia, we need to identify the grade, whether it's low or high. That will be determining the further management of the patient, and some additional methods, immune, histological, or others, pathomorphosis. Further, so we need to not just to confirm or clarify the histotype of the malignant neoplasias, but just to trace their progression. So we have 244 patients that we studied. There was an article published with the findings on the assessment of the effectiveness of the fine needle aspirational punction of the pancreatic lesions. And just the sensitivity is 81, specificity 90%, and accuracy is 83%. This is quite comparable with what Alexander reported on, and there was an original articles with solid lesions. The sensitivity is 90.8 and specificity 96.5, and the cystic sensitivity is 51%, which proves that we really face challenges in morphological diagnosing process, especially with the cytological material, which I already covered. So the conditions that we need to ensure to have the reliable morphological report, the first two is the high quality aspirational biopsy, so the cell material and good preparation for the material, representational glass preparations, and the experience of endoscopist. So this glass preparation is very good, so that the smear is quite thin, whereas in the second and third material has the excessive fibrin layer, and it aggravates the diagnostic procedure. So the quality interpretation of morphological changes is the third major condition. The theoretical training of the cytopathologists. It's important to have a more experienced mentor and the experience of working with this material. So what we do in our laboratory, we have the comprehensive morphological investigations and studies, so using traditional smears with staining, with liquid cytology, and we have the conservant to put our material into, and we have just very fine, thin smears, which can be subject to very high quality microscopy, and this is what differs it from the traditional cytological method. So the cell block preparation, so formalin and other liquids are used, and then immunohistochemical study and molecular genetic study. Molecular genetic is a very important component of the process. We can use any type of material, smears, a cell block, and others. It expands our opportunities in comprehensive diagnostics, and comprehensive integrated diagnostics is very good, because differential diagnostics puts us in front of the different challenges like reactive epithelium and contamination, and others. So gastric contamination, duodenal, and others. And without additional methods and additional studies, it is sometimes very difficult to finalize the research. We need the clinical information about a patient with a major symptoms, age and sex, the CT, CAT screen, MRI, and just ultrasonic protocol, so we could see the major points in the lesions and others. We need the data from laboratory tests, especially if we need to deal with the cystic liquid and amylase in the cystic liquid, and the molecular genetic analysis, which sometimes is a crucial factor in the whole process. And our colleagues from Massachusetts University have developed their own protocol of working with the cystic liquid. They propose just break it into two. One goes to morphological and genetic analysis, and then you use the second part to analyze the CA, amylase. The genetic mutations here have great importance. Sometimes they are crucial for morphological studies, such GNAS and other markers. They're going to be dwelt upon in further presentations. I'm not going to focus on it here. Male patient 53. So this is cystic lesion, pancreatic lesion in the so with contours and multiple different size cystic cavities. So we just expected this kind of diagnosis, as you see on the slide. So we performed the following studies here. In cell blocks, you have individual cells, monomorphic. Just when immunohistochemical staining, we see the expression and the index of proliferation activity is Ki67. And here we have neoplasia, G1 neuroendocrine type with the expressed cystic component. And further on, we are planning for a surgery basing upon this diagnosis. Also, the modern diagnostics of the pancreatic lesions is a specialized section of morphological diagnosis, including the cell and tissue material studies using immunohistochemical and molecular genetic analysis. And we need to develop and introduce the different just norms and standards and standardized protocols, not only on the endoscopic, but also at the processing stages as well. So to minimize the unreliable morphological or inaccurate results, there should be a specialized laboratory. There should be rules to observe to prepare the test samples, their marking and preservation, and having support documentation, which will have all the information about the patients and their tests. And it has to be performed by high caliber experienced experts, which is a crucial factor for providing good health care to our patients. Thank you very much. This is our interdisciplinary team, just I'm part of. Thank you very much. Thank you very much for your presentation. It was truly exciting. I could have asked a question, but I know that both the histological and morphological biopsy-related methods, they go hand in glove. In your department, you do both morphological and cytological, but for Russia, it is not typical on on the whole, then I would like to draw in Alex into our 2-minute discussion. So it is accustomed that this cytological smears are part of the some laboratories, and histological formalin-related studies go to pathomorphological laboratories. So different laboratories deal with it. So the question first to Sergey and then to Alexander, if we need to comment whether it is important in the process of diagnosing. Let's focus on the pancreatic pathologies, not involving any other areas. Well, I think that cytopathology and cytology is a subspecialty of pathological anatomy. So all the studies we perform and tests we perform related to pancreatic lesions, these are morphological ones. We think they should be performed by morphological laboratories in pathology departments. In terms of the Western medicine, it means that part of the studies is performed by cytopathologists because they are trained as pathologists, primary training focus, and the histological studies are performed by other specialists, but in a framework of a team. As to our specific example, I think it's a good solution when a pathologist that is specializing in cytopathological deals with the whole block of cytopathology and cell block, immunohistochemical investigations, and he takes a decision on the necessity of molecular genetic studies. So Alex, in your clinic, what is the situation like? Do you differentiate between cytological and other morphological studies? Are they performed in different departments? And what is your idea about it?
Yeah, thank you. This in Germany, we might be a bit behind your way of doing it when I hear this, because we just got one way of putting this. The US samples, for example, we put in a formalin liquid, and this goes to the pathology lab, which is inside our house, which is good. So there's no time lag, but on the other hand, there's no different specialization for the pathologist. So one kind of pathologist will look at all of those samples, and it might be a good thing if there was a specialty there, but we don't have it.
Well, thank you for your comment, and just we need to move on, and I'm turning the floor over to Vladimir Nazarov, who is going to tell us about the molecular genetic aspects of diagnosing pancreatic neoplasia. He's a laboratory geneticist, as doctor of clinical laboratory diagnostics in the Academy of Molecular Medicine. Thank you very much, dear colleagues. It was a great honor for me. We cannot hear you, unfortunately. Have you switched on to the Russian language? Maybe you have to switch. Just giving directions how to switch to the Russian language, because the audience cannot hear the presenter. Dear colleagues, can you hear me now? Yes, now it's okay. We can hear you well enough. looking forward to a presentation. First of all, I'd like to thank for this kind invitation to be part of this important and representative congress, as wanted to speak about the cytological and studies in the Russian Federation. And I also support the idea that the cytological studies should be made by pathomorphologists. Now let's go back to discuss the topic of my presentation, is molecular genetic aspects of diagnosing pancreatic neoplasia. So this kind of cancer is not the most common cancers, but it's the most aggressive, and the 5-year survival is only 10%. Lamentably, it depends on the stage at which this condition was identified, but this is the average statistic, which is like this. About 80–90% of all cases of the pancreatic cancer is the duct adenocarcinoma. And so the cancerogenesis situation now includes the staged process and the pre-cancer conditions like ductal papillary mucinous tumor and others. So the stage-related process of progression of the pancreatic cancer is very similar to the colorectal one. So we have inflammatory, mechanical defects, genetic, because it's mostly a hereditary condition, and it is not clear whether it is itinerary or just the duct cells that trigger off cancer process. There is a phenotypical transition from the low-grade tumor condition to the higher grade, and then to the malignant tumors. And at first stages, the molecular and genetic event is the mutation in KRAS gene. It is good that we understand if this mutation is here, so this is an onset of the cancerogenic process, and we can use it as a diagnostic marker. So then all other CDKN and 2A mutations, TP53 and others accumulate, and then trigger off the phenotypical changes in the process, and final result in the malignant tumor. So KRAS mutations is about 90–92% of all cases. We're not taking the KRAS mutation with the coexistence with the co-driver mutations like TP53, SMAD4, and others. These genes are less common, and they're quite rare. Event is the top one. So the KRAS mutations are manifested in exon Y, exon 2, and you can see the subtypes, but mostly these are exon 2 mutations. You can see them on the slides. How can we use this marker in diagnosing the pancreatic cancer? It is an integrated approach using CT, MRI, clinical manifestations that are not very visible. They become more visible at later stages of the condition development, and endoscopic and ultrasonic and other studies. So we need to define needle biopsy, which is an important method to identify the solid and other neoplasia in pancreas. So fine needle biopsy guided with endoscopic ultrasonic technique. It is used for difficult cases. Staging of this malignant tumor has to be based on the CAT screen manifestations. So the and biopsy and other methods should not determine the choice of the surgery or the time when the surgery is resorted to. However, this fine needle biopsy is important in the diagnosing process and appointment of the adjuvant chemotherapy. There are 6 categories, like Tatiana said, in this classification. It's a non-informative, negative, atypical, neoplasia, and others. So there are about 20 patients with unclear cytological significance. And there are some difficulties arising in their interpretation. The sensitivity in identifying the neoplasia with the fine needle biopsy accounts for 45–90%, depending on the experience of the endoscopist and just the experience of the pathologist. However, specificity accounts for 100% and the accuracy 85%. However, the cytologically unclear cases account for about 20%, but it varies from a case to case. So differential diagnosing is based on the gene KRAS mutations with ductal adenocarcinoma. This KRAS gene is seen in 90% of cases, which gives us an opportunity to use it one of the markers and base our diagnostic process on it further on. So molecular and genetic methods give good opportunities to study any samples from cytology, the cytological smears on glass and cytological blocks, and new PCR method, new NGS methods, and we can identify these mutations with high degree of accuracy. However, there is sensitivity from relating to different molecular and genetic methods. We use PCR in real-time, liquid, NGS or other methods, which have very high level of sensitivity, able to identify 0.101 of the mutant DNA. Some of the methods are outdated, however, they are used, and the old publications were basing on this particular outdated method, and their sensitivity and specificity should be viewed with a healthy viewed quite skeptically, because the more recent methods provide more accurate data. Using cytological study and a parallel KRAS mutation study increases the sensitivity of the pancreatic cancer studies. And here you can see some of the works with the important findings for using this marker. These studies show that cytology plus KRAS mutation studies allowed to increase the sensitivity for over 30%. Compared to only positive or negative cytology patients. However, including suspicious cancer conditions in it, decreased specificity, but still increased sensitivity. In all groups, the KRAS mutation inclusion cytology increase the sensitivity and identification of the lesion. If we discuss, were to discuss the differentiated cancer, pancreatic cancer and other conditions, here using KRAS gene mutations allowed to increase sensitivity once again. Here you can see that the methods of diagnosing vary in their final outcomes, and sometimes specificity can be lower in some of them, And early, there are KRAS gene mutations at an early stage of the condition. We'll discuss it later. Also, some of the challenges when acquiring material samples, it has been already discussed by Tatiana. We have contaminated samples with intestine and blood contamination cases. Here on the slide, you can see, so there was a contamination. The biopsy was judged as negative with aggregates of the cylinder cells and atypia that were just the KRAS mutation gene identified the gene G12V mutation, and then the ductal adenocarcinoma was diagnosed during the histological study. However, it increases the sensitivity of the diagnostic process. Let's discuss the molecular genetic, using molecular genetic markers when we deal with cystic lesions, pancreatic lesions. I'm not going to take you through the modern cyst type lesions classification. We have malignant and we have benign. And so this progression chances for this pre-malignant are quite high. And just to differentiate between the benign and pre-benign and pre-malignant and malignant is the fine needle biopsy as a major method to differentiate between these types of cysts. So it's this, so sensitivity is 3691, and you can see the KRAS gene with in cystic pancreatic lesions. So this might be used as a marker for differentiated diagnosis between malignant or potentially malignant and non-malignant cysts, tumors. Mutations in KRAS gene is between 14 to 40% in mucin cystic tumors, whereas the KRAS genes in interductal papillary mucinous tumor are quite high, up to 80%. With low-grade tumors also have 30% KRAS mutation, and with the progression, it goes to 80% of KRAS gene mutation, and it complicates using this marker for differential diagnosis. Here you can see two major studies of KRAS mutations, and they're used for differential diagnosis of mucinous and non-mucinous tumors. So it's a highly specific marker. So with for mucinous cyst and malignant cyst, it accounts for 9600% without taking into account their grade being low or high. So 56% is quite low sensitivity, and then identifying high grade mucinous cysts and malignant cysts that require surgery. Here they are diagnosed as slow grade cysts. A mutation, KRAS gene mutation, has both low sensitivity and specificity to diagnose these two particular conditions. Despite this, modern guidelines have it that when dealing with complicated cases to diagnose these three types of cysts, it is possible to use KRAS gene for two states, but not for appointment of surgery as a management strategy. It is very important to understand it because it's a pending problem, because gene KRAS mutations manifest themselves quite often in low-grade pre-malignant conditions which not require any surgical intervention. And using, another challenge is quite a low level of sensitivity of these markers, NGS and other methods when they are part of the routine practice. Might change the situation with low sensitivity, and we will be using high specific molecular genetic methods in the future. And so far we have no possibility to differentiate between high grade and low grade based on the molecular status. However, I think the microRNA and other methods will change the situation for the better. Once again, these are the major conclusions of my presentation. So the combined use of molecular genetic diagnostic with cytological study of solid pancreatic lesions increases sensitivity and specificity of the study with the cyst lesions, identify mutations in KRAS gene, helps differentiate only between mucinous and non-mucinous tumors, and KRAS mutation studies does not differentiate between low-grade and high-grade pre-malignant conditions, which increases the risk of undesirable surgical manipulations while identifying these mutations. Thank you. I've kept the time frame, so I'd be happy to take questions if any. Thank you very much. It was really a very interesting presentation. And I hope my colleagues will agree that it has a very good potential, this additional block of morphological studies, which very soon will be an indispensable component of the general procedure, but we need to move on. And I'm inviting the next presenter, Sergey Olegovich Kuzin. They're going to co-present it with his colleague, Mr. Rykov, from the Russian Academy of Sciences Clinic. Are you ready? Yes. So the clinicist's viewpoint on how we can use the material that we obtain due to morphologists and their molecular biologists. Good afternoon, dear colleagues. Thank you for the invitation to take part in this conference, and as we're going to use the next 15 minutes to discuss the possibilities of using the results of the morphological studies and morphological and biological studies in the clinical practice. Why is it so relevant at this stage? We know that the pancreatic tumors and lesions cases are growing, as well as morbidity, be it biliary pancreatobiliary tumors or pancreatic tumors. You can see the statistic is growing. Some time ago, it was enough to just use the traditional data to diagnose, but then we started implementing the cutting-edge technologies in our routine life. So we are using gene markers and other methods. These are the ones that help identify satellite conditions and hereditary, especially. I would like to first focus on the pancreatic lesions and tumors to begin with. So it is very relevant when we get patients with cytostatic process, so quite young ones, where first line therapy is very important for their further health condition, and just without imaging we cannot tell what it is that we will see in the future and what will be the management strategy. From the point of view of pancreatic tumors, we have two major variations, morphological variations, is neuroendocrine and neuroendocrine endocrine. In neuroendocrine ones, we have many alternatives. It's observation at a low grade, then progressing to chemotherapy, radiation therapy, and others. And when pancreatic adenocarcinoma, we have limited choices. And the second line is our limit. So this kind of therapy is the only thing that we can offer to our patients. So pancreatic adenocarcinoma are based on the following recommendations and of ESMA. So they, apart from morphological variations, additional testing is not required for all patients, especially for those who will further undergo a surgery. So it's however, when we deal with the NCCN guidelines, we see that there is a specific group of patients who have two-chain breakages of DNA with a BRCA2 or 1 mutations and other mutations. These patients are recommended in a platinum-containing therapy. Platinum is one of the mechanisms of its action, is just multiple breakage of DNA, and how these drugs will be more efficient for this group of patients. We know this. We have quite a big number of observations and singular reports that show that this group of patients improve their survival if they take the platinum-based drugs. That decreases the progression rate, and the response rate is higher. So the most significant results in terms of platinum-containing drugs were obtained cisplatin and Ginzar. About 50 patients were part of this. And thus platin and others were the two major strategies. It didn't show any increase in the overall survival. However, the response rate in these two groups was the gender cisplatin and others was 74 as the objective response rate. If we were to view the control group, there was about 100% of this. They did not have any progression when they received this medication. So basing on these results, it was established that PALP or VERSI mutations, if they are known to be there, it is more efficient to appoint platinum-based chemotherapy. As you can see the POLAR trial results here, it was confirmed with the platinum-based drugs efficiency was confirmed. We can see that the FOLFIRINOX that was but 129%, the overwhelming percentage, had better results than the other patients that were subject to first-line treatment. So the patients who did not progress within 16 weeks having the first-line treatment, they were treated with allofurid or other drugs. So with the just lower progression was not affected by it. in Apollo trial, there was no crossover, there was no transition of the group who would be progressing on placebo for olaparib group. So there is another interesting study. Fogelman and colleagues performed an analysis, and he showed that it was important for risk and other classifications was important, but the number of relatives with the confirmed mutation was important. So the higher survival rate was with patients with three relatives with confirmed cases or in the 3 generations. As to additional markers that we can use for chemotherapy, it's which is lower than 2%. It is not immunotherapy will work. 22 patients were part of the group. 4 of them had a response rate of about 14 months. As to mutation load, in clinical practice, we are not using it as a routine procedure because it is quite an expensive one. We know so the zonal 0.28. There was additional load, or 2 patients, and satellite instability was not registered in these 2 patients. Another marker that can be used for all tumors is NTRK marker. There are 2 drugs, Laura and others, that are used for these for all lesions and tumors. We know that the prevalence is quite low. Only 3 patients that were part of the group, all the 3 had the response, and NTRK markers were included into the standard protocol of treatment. What does not work for pancreatic lesions today? There are findings that show that HER2 expression adds nothing in terms of new drugs or old drugs that could be used to treat the tumor. All that immunotherapy in classical without involving MSI-H and TMB-H is not very efficient for pancreatic tumors. Neuroendocrine lesions, pancreatic lesions, we see the NCCN guidelines in both in G1 and grade 3 and non-differentiated tumors. We do not see any indications that would reveal some new molecular genetic modifications. And in the clinical practice, for these patients, it is important to diagnose them, whether it's a G1, G2, or others, and there are different related methods of treatment here. A few words about the molecular landscape of the biliary tract tumors, biliary zone tumors. So the first line is chemotherapy. There are no further findings that would be indicating the need to include this target markers as drugs. So so you can see the statistic here. The response time is up to 25 months. The microsatellite instability in cholangiocarcinomas accounts for 3 to 10%, and it decreases significantly with the cytostatic process triggered off remains lower than 1%. as to increase tumor load in lung carcinomes. So none of the 22 patients did not have a high mutation dose. The marker that theoretically can be studied and used basing on the drug studies is PD-L1 overexpression. 18 out of 42 patients had expression of over 1%, and nivolumab had this 9 out of 20% of patients had this response. However, there is not great difference shown. Whether it is there is such an expression or not, it is the response is not as high as we would have wanted it to be. So another potential marker that could be used in the future is FGFR2. This FGFR inhibitors is pemigatinib. So the final point of the study was the response rate, which was about 36%. Just in the control of the condition was about 80-something percent. It was a treated group of patients. It was very good result as of today. And there is a new study, the first line of chemotherapy, that is cisplatin with pemigatinib added. Another marker that we can potentially use in clinical practice, unfortunately, there are no drugs available in Russia now, it's IDH. IDH1 manifests at about 25% and IDH2 in about 3% of patients with pancreatobiliary tumors. So they were taking ivosidenib, 50 milligram 1 time per day, 187 patients. But it was there is a quite skeptical attitude to ivosidenib in the Western world because it is quite an expensive drug, over $1,000, and it was not very efficient to use it. Another potential marker is BRAF. So ROA trial was phase 2. So it's dobrakinib and metinib. So overall response rate 47 with stabilization 14%, and median PFS was 9 months. It was for a person who already was subjected to chemotherapy during the first and second line of therapy. So it was quite a promising outcome. So what other things? With the pancreatic adenocarcinoma and other conditions, it is recommended by NCCN guidelines to search for new potential markers, as NGS and others, to be further used in routine therapy, and familial and hereditary mutations in families who should be subject to earlier screening and diagnostic, who are on the high risk of developing these conditions again. So take-home messages. My information is targeted at clinicians. So in pancreatic lesions, the overwhelming manifestation adenocarcinoma, so or neuroendocrine tumor, verification process is very important because these two tumors have different prognosis and have very different treatment. Clinicians should be looking for additional morphological and molecular genetic markers of the pancreatobiliary zone, which will determine the treatment strategy and the prognosis, and additional genetic testing is desirable in order to identify the additional markers or system screening that could be relied on in the further strategy of management. Thank you. Thank you very much for this information. We do see the necessity of a more accurate diagnosis in terms of the biological, morphological, and genetic perspectives, and the biological and molecular genetic methods are coming to the fore. And the final presentation, calling up all the final presenter, is going just to deal with this 10% of neuroendocrine lesions in pancreas, and turning the floor over to Uliana Alexandrovna Tsoi, who is head of the neuroendocrinological department and Almazov Academy expert. The floor is yours. Could you please turn on the presentation? Just giving instructions to the previous presenter, he needs to remove his presentation so that the new one can be put on. Again, calling upon the previous presenter, we can still see his shared screen, but we need to put on a new presentation. Well, now we have it. Thank you very much. And let's embark upon the final presentation. Thank you, dear colleagues. I would like to begin by saying that I'm an endocrinologist. I'm not an oncologist by training, and I deal with treating and managing endocrine patients. And I'm proposing to look at this subject matter from this perspective. Neuroendocrine tumors in pancreas make the most common group of patients, about 70% of all patients, and we also face the need to manage such patients. But 2% of all pancreatic tumors are endocrine, according to the autopsy, up to 10. And this is not just an oncological disease. They also have a possibility to synthesize and secrete hormones. 70% of such patients are non-functioning endocrine tumors. 10% are inherited syndromes, and we have highly differentiated and low differentiated lesions. As to the management strategy, it depends on the cell differentiation and proliferative activity, staging of the TNM system, functional activity, and association with hereditary genetic syndromes. I'm not going to dwell very in detail upon the classification that deals with the cell indifferentiation and proliferation activity and classes, and which determines the observation and management strategy. Here we deal with the oncological process. We have already discussed it a lot during today's session. However, the specificity of neuroendocrine tumors is that there is quite numerous groups of patients in which neuroendocrine tumors are synthesized and secrete hormones. We need to remember about this, and such patients require a special approach because the hyperfunction of their hormones determines our diagnosing and management. Also, we need to remember about the genetic inherited syndromes that are associated with the neuroendocrine pancreatic tumors. Insulinoma is one of the most common situations that we deal with in our practice. This is a tumor that secretes insulin and triggers off the hyperglycemia syndrome. We need this to perform this hunger test, and in 90% of patients receive surgery, and they go back to normal life. However, in majority of cases, these patients have very low grade 1 or grade 2. In seldom cases, they have to undergo surgery, even if it's under 2 centimeters, and we need to treat the endocrinological syndrome and take care of this very specific biology of tumors as glucagonoma. It's also quite a seldom and neuroendocrine condition. You can see this migrating erythema, which is a genetic marker of this condition, and the second type of diabetes. We also resort to therapy of the somatostatin analogies and surgery. We identify the glucagon in the blood tests and others. So ectopical AKTG syndrome, they are quite common. Up to 16%, make about 16% of all the neuroendocrine pancreatic tumors. At the diagnosing moment, the tumor has some metastatic dissemination. There is another specificity of neuroendocrine tumors. They can express hormones. We can see this hormone expression during the morphological test. However, they can discontinue secreting it, and started interval. So with ectopical AKTG syndrome, the tumor can start expressing it, and it can start secreting it, and we have hypercorticism syndromes, and patients progress very quickly. Their condition deteriorate dramatically. They get to be viewed as hard hit patients. Why didn't it reveal itself before? Exactly because of this specific feature. When we have just the biopsy, we can see that it's neuroendocrine condition. It is important to assess the gene expression, because they have almost no clinical manifestation. But since we know it, we will take it into account while observing and managing such patients. Gastrinoma, it's the gastrin synthesizing tumor. It's a recidivist gastric ulcer. We identify these patients when they already have meds, and sometimes the first line is not efficient, so then we use the proton blockators, and histamine blockators are not so efficient. And very, very seldom it's this NEO, the secrete vasoactive intestinal polypeptide, the Werner-Morrison syndrome with the diarrhea and other express symptoms. If we identify the patients with some meds at somatostatin analogs of the first generation are quite helpful. Carcinoid syndrome is also quite seldom. Just neuroendocrine lesions of the gastric tract. So pancreatic, pancreas can also contribute to serotonin production and aggravating of the case. When we see the patients with the neuroendocrine tumors, we understand that part of them are associated with gene syndromes. How can we identify them? On the one hand, while making a genetic test, NGS is a preferred method because we can assess a number of genes at the same time. We can identify mutation. However, when we further test the carriers of the mutation, which is associated with the neuro tumor, we need to test them for neuroendocrine tumor of the pancreatic gland. And when we see the manifestation of this or that, and when we know that it is associated with neuroendocrine lesions, we need to take it into account. So these syndromes include MAN1, the Vermeer syndrome, so hyperparathyreosis, and different adenomas of others. Here we need to test the patient for the tumor, especially when we say the pituitary gland. So sometimes these tumors are quite small, but can be multiple, and may not be identifiable with CAT screening or ultrasonic test. Here we can see the syndrome MAN1. We sometimes see gastrinomas and insulinomas, so which can be multiple and might be repeated, and we need to identify the most optimal treatment. The von Gippe-Lindau disease, it is autosomal dominant condition. We can see the condition components and others. So sometimes pheochromocytoma patients manifest the symptoms in a very express way. So we need to assess the hormone parades, and we need to identify and assess the structure of the pancreas and the retina structure as well. When we have Gippe-Lindau syndrome, it's non-functioning, unlike MAN1. It's sometimes is malignant, and we can see the correlation depending on size here. If it's below 2 centimeters, they are benign. If they're over 2.5 centimeters, here we can expect the progression of the process, and we need to use a more active treatment. Neurofibromatosis of type 1, Recklinghausen disease. Here there are hormonal active syndromes, stages of the syndrome. So adenocarcinoma might be one of the related conditions. So if the diagnosis were to be reliable, we need to take into account the structure of pancreas as well and test it. There's tuberose sclerosis, the Bernville condition. There's TSC1 and TSC2 gene mutations trigger of this condition, and these are suppressor genes. The gene that codes the tumor growth suppressor proteins, and triggers on the formation of benign lesions. Here we can see TSC2 leading to this condition. However, quite seldom, under 1% of cases, there's functional and non-functional, and maybe malignant. It is important to remember that the neuroendocrine tumors, or pancreatic neuroendocrine tumors, because of their biological features, require additional attention, not only on behalf of oncologists, but endocrinologists, geneticists. So there should be a more wide-ranging cross-sectoral team of doctors, of physicians to manage such patients. Thank you for attention. Thank you very much, Juliana Alexandrovna. You revealed an integrated, complex challenge when we deal with pancreatic lesions and also other symptoms that pancreas can be involved in. We have already overused our time. We have no time for Q&A period, unfortunately, but it is always the most interesting, exciting part of any discussion. However, I'm inviting just closing remarks, your impressions, maybe your comments, maybe some of the wishes as a part of the final words of the session. Alex, you're welcome.
Yeah, thank you, Evgeny. For me, it was a great pleasure to take part in this prestigious session here, and I followed all the talks quite closely, and I must say I learned a lot. It was a good combination of clinicians and pathologists and oncologists, and there's always a lot to learn when we work together and talk to each other more often than just writing emails. So thanks a lot.
Thank you very much. I would like to thank Sergey Olegovich for his presentation. Vladimir Dmitrievich, thank you very much for taking part in our symposium. I think we will be moving on in this chosen direction. We will see each other more often. Sergey Leonidovich, you as a representative of the morphology groups, a couple of closing words. Thank you. I think we have had a very interesting session, which demonstrated how relevant the topic we discussed is. And I think that this topic will be a recurring one in the framework of the Almazov-hosted symposia and conferences. I'm really convinced that it should be so. And in conclusion, I would like to say that our way forward in managing such patients is a staged process. We learned about new advanced technologies, about international experience, about guidelines and for managing such patients. And we have been cooperating with different partners for 7-8 years now. We have accumulated our own experience to perform the analysis of the challenges and issues that are to be put for discussions during the upcoming conferences. We need to demonstrate our own findings for this cohort of patients. And we can do it only provided we rely upon this multidisciplinary trend in terms of exchanging experience and data on each individual patient and exchanging expert findings and opinions. And I think it's a crucial factor for further, more effective treatment. And I think we will have further meetings and it'll go on. Thank you very much. I'm fully with you in that. Let's start thinking how we can ensure this. So an idea of neoplasia-related pancreatic neoplasias conference would be a very good idea. So it will stem off this session. Of course, during this an hour and a half, we could only outline the circle of issues and problems that we face in our clinical activities. So I would like to thank everyone for attending this session. See you soon, and I hope we will continue along these lines. Best of luck. Thank you very much. Alex, thank you very much for attending our conference. I haven't seen you for ages. It's the only opportunity to see you on the monitor screen. Thanks a lot again. See you.